What is considered high-risk multiple myeloma? Is this a standardized definition? High-risk multiple myeloma is a subgroup of individuals who may not respond well to standard myeloma therapy and often have poor outcomes.
So HRMM is high-risk multiple myeloma, and the definitions are all over the place. The easiest way to assess risk is to know your stage. In the current second revision of the International Staging System, which involved the categorization of 10,000 patients for outcome, there were genetic variables that were identified as risk, and there were variables that kind of look at how rapidly the myeloma cells grow, that's indirectly measured by the LDH, and how much myeloma there is, which is measured by the beta-2 microglobulin. So there's the disease burden, if you will. How much myeloma do you have? How fast is the myeloma growing? And does the myeloma have genetic features that could lead to chemotherapy resistance over time? Having said that, experienced clinicians know that there's a difference between treating an 85-year-old and a 55-year-old, and treating someone with emphysema, insulin-dependent diabetes, coronary artery disease with prior heart attack. Those may not be high-risk biologic features, but it's going to make treatment more complicated and more challenging and may limit which medications are safe for a patient. There are those variables that you can recognize at the time of diagnosis and those variables that appear later on, such as you get treatment with a very effective regimen and it doesn't work that well. The response depth isn't good. That suggests there's some inherent resistance of your myeloma to the treatment, and that can be challenging going on. Or patients who have an extremely good response to treatment, but the disease is already starting to grow back within 6 to 12 months of initial. Those patients also carry risk. So there's not one standard definition for risk. There are guidelines that exist. I think probably the best for a given patient is know your stage.
The definition of high risk is really evolving a lot. So we have some data that it's old data and from the past, that is P53, 414, 14, 16. This was discovered, I don't know if 10, 15 years ago that they had high risk. But now we are now tuning this definition because we know that some P53 patients do not have high risk. They are not really high risk. And that depends on many things, on the proportion of cells that they have or the type of mutation or deletion that it has. We know that there are other patients by NGS or other methodologies that they may have other P53 abnormalities that are not captured by FIS. And the same happens with the 414 translocation, 1416, and even novel abnormalities we are discovering now with novel techniques. So this is really evolving. And at the end, and as it is evolving the treatment and the approach or the management of this, so this is completely changing over time. What is good is that we make progress, we adapt treatment again. I mean, the treatment adaptation based on that, because maybe if we are now using a novel mechanism, then we can overcome the high risk. So adapt treatment and change things about regarding as it is the disease of the biology of the patient.
It's a broad definition because you have high-risk cytogenetic abnormalities or aberrations, and they are pretty standard. It's translocation 14, 16, translocation 414, and deletion 17p, amplification 1q, and maybe even also intermediate, maybe translocation 1114. But then you also have a high level if you have a high level of LDH at diagnosis, it is a poor prognostic marker. Also the ISS scoring system, which is pretty simple, is important. And then again, if you have an early relapse after your transplant, then you have a very poor prognosis. But this is more dynamic prognostic marker. The others can be assessed upfront at diagnosis. So this is high-risk markers. It's a broad definition.
Who else may be considered high risk?
I can add to that, because usually you talk about these high-risk markers and also the blood test with ISS. But the thing is that comorbidity is just as important. And that's something you should really include as a high risk, because then you can't have the same treatment as others, and then you are at risk.
Why is the definition of high-risk multiple myeloma evolving and changing?
So the high-risk definition, it is always changing. And so part of that is because our treatments get better. So something that might have been high risk before is not considered high risk. An example of that is deletion 13q, which is quite prevalent and it used to be considered high risk, but now is no longer because modern therapeutics have made that obsolete. 414 translocation is another one that historically, and is still sometimes considered high risk, but proteasome inhibitors seem to really specifically improve the outcomes of that. So that's why the risk definition is inherently a little bit unstable, as it should be, because our therapeutics keep evolving, but also our technologies get better, right? So for example, in the US, there was a very interesting presentation that 50% of patients who get FISH testing done are not enriched on plasma cells. So what that means is when their bone marrow aspirate was tested, they looked at the entire aspirate, not just the myeloma cell. So that's important because you want to know if somebody has a certain high-risk feature, such as deletion 17p, is it in a few cells or many cells? Because some studies say that the amount matters. So you need to know the percentage of cells that have the abnormality. You need to know whether what's called allelic burden. So if you have 17p and you have 2 chromosomes, did you lose one or both? And there's also the mutational status, right? So is it deletion or overexpression, underexpression? So it's complicated. So I think ultimately the purpose of these, whatever you call high risk, should be able to pull out the patients that you'd be more worried about.
High risk is a moving target, so it is a hard thing to define. I think the presence of 17p deletion is clearly a high risk subset. Patients that have 14-16 translocation by FISH also are a high risk subset. The use now of 1q amplification in combination with those high risk factors are also concerning for high risk disease. And patients that have routine cytogenetics, so karyotypic abnormalities, fall into a 15% of patients that are proliferative, and we call them high risk as well.
Is there a clinically high-risk group of patients?
So the clinical high risk is really an interesting question. And I think that patients who present with true extramedullary disease at the time of initial presentation, meaning they have myeloma that's growing outside of a bone, that will act like high-risk disease. Patients with plasma cell leukemia,